program on coordinating a community response to the opioid epidemic will be presented by Molly Welch Marahar and Carrie Rheingans from the U of M Center for Healthcare Research and Transformation, and a panel that they will introduce to you. Molly Welch Marahar is a Policy Fellowship Program Manager at CHRT, where she manages CHRT's Policy Fellowship and provides analysis of issues and trends in healthcare policy. Prior to this, Molly worked in the Substance Use Treatment Center for 4 years as both a counselor and a recovery support specialist with Dawn Farm. She was also an Omen Daring Health Policy Fellow with Breast Cancer Action in San Francisco. Carrie Rheingans, a project manager at the Center for CHRT, where she manages the Washtenaw Health Initiative and other community implementation activities through the State Innovation Model and the Michigan Community Health Worker Alliance. Carrie is also an adjunct lecturer in the University of Michigan School of Social Work, teaching courses on healthcare policy, community organizing, management of human services, and social policy and evaluation. She also serves as a board member for Communities Joined Action, which is a national membership organization of community coalitions working to improve health in communities across the country. Please join me in welcoming Molly, Carrie, and the panel.
Hi, everybody. I'm Molly Welch Marahar. This is Marci Scalera. She's going to be presenting the slides with me. We're here to talk about the Washtenaw Health Initiative's Opioid Project. I am the Opioid Project Coordinator. That's part of my work at the Center for Health and Research Transformation. And Marci Scalera here is one of our co-chairs. You want to introduce yourself?
Sure. Hi. I am the Clinical and SUD Director for the Community Mental Health Partnership of Southeast Michigan. We're the funder for the 4 counties for substance abuse treatment and prevention services and recovery services. So you may have known me somewhere along the line, but that's who I am.
So we'll jump right into it. So we're here to talk to you about coordinating community response to the opioid epidemic. And what we're presenting you tonight is based on our work as a cross-sector coalition that we formed to address the opioid epidemic in Washtenaw County. So you don't need to be able to read this. This slide is to just give you a sense of where the Opioid Project lives in a broader coalition, which is the WHI, which stands for Washtenaw Health Initiative. The Washtenaw Health Initiative is a collaboration of over 200 stakeholders from across Washtenaw County, and it formed to make healthcare more accessible for uninsured, underinsured, and low-income residents of Washtenaw County. And so the Opioid Project is one of several projects under the umbrella of the WHI. And we're actually under a project under the WHI, which is the Mental Health and Substance Use Work Group. So there's several work groups, and then the Opioid Project is an offshoot of one of those work groups. This is to just kind of give you a sense of what we are. The WHI is supported by the Center for Health and Research Transformation, which is where myself and Carrie come in. We are staff at the Center for Health and Research Transformation, which I'm going to refer to as CHART from now on to make it a lot easier on myself. At CHART, we perform what's called a backbone function, which is essential to coalition work. So we basically administer the activities of the coalition, because everybody else is a volunteer. But we are funded basically to perform these activities. And the WHI is a much broader backbone coalition, and the Opioid Project is a smaller coalition kind of within that group. And so that's us, that's where we live, kind of in that area. So these are our Opioid Project co-chairs. We have Marci, who's been with the Opioid Project since its formation, and then Jimena Lovelock, who more recently became a co-chair. She's with the Washtenaw County Health Department. Unfortunately, she couldn't be with us here tonight. But I think it's important to point out when we're talking about the leadership of our group, the fact that we're represented by the health department and the coordinating agency for substance use, which is really kind of important in terms of getting the buy-in for a lot of the work that we do in the community. So this is the Opioid Project staff. That's me, and that's Carrie. Carrie is the project manager for the overall WHI, and my work is just basically within the Opioid Project. So Jimena and Marci, they volunteer their time. Carrie and I get paid for our work. So we basically perform all the activities of the hub. So the hub is kind of that backbone function that I referred to. So before we jump into our coalition work, we kind of want to give you guys a sense of what the opioid epidemic looks like in Washtenaw County. Here in Washtenaw County, we are blessed with an amazing epidemiologist at the health department. Her name is Adrienne Waller. And she really goes out of her way to collect and translate data relating to opioid overdose and adverse outcomes from opioids in our community. Not every community has this, so we're really lucky. This here shows kind of the trend in both ED admissions and overdose deaths from 2015 to 2018. You can see it's generally kind of on the up in terms of ED admissions, and in terms of death, it's been kind of consistent. It's really kind of hard to tell a lot of the time whether our coalition is having an impact. We have to sometimes rely on the softer kind of the softer stuff, the relationships that are built, the partnerships that are made, but we are lucky to be able to follow this kind of data pretty closely as we do our work, and it helps us kind of zero in our efforts where they need to be. I just think this is another one of Adrienne's pieces of data to kind of give you a sense of the scope of this issue in our county. There was more years of life lost. And this is, partially because the people who are dying from opioid overdose are younger. So, that's pretty significant, I think. This is a map of Washtenaw County, as you can see. This is data from 2014 through 2015. The red refers to the areas where overdose death is concentrated. As you can see, those two zip codes are Ypsilanti. And then you can also see that there's, in kind of the more rural parts of our county, overdose is pretty high. This is another map. So the pink-purple dots are ED admissions, and then the blue-purple dots are overdose deaths. This is cumulative data. The information on this slide, unfortunately, is incorrect. We're using an older version of these slides, but this is cumulative data from 2011 to 2017. And you can see that, a lot of the activity is very much concentrated on the east side of the county, which is relevant when we're thinking about where we need to target resources, what kind of groups we need to engage in our work, and generally what areas are being most impacted by this epidemic. Okay, I'm going to hand over to Marci now.
So what this group has done, and we really started to come together in about 2013. Actually, we started noticing at the coordinating agency back in 2009, 2010 that we were starting to have kind of an opiate epidemic. And we were noticing there were more heroin admissions and sort of this uptake of people with opiate use disorder coming for services. And we knew that we were having some problems with prescription drugs. And so back, actually I think it was 2009, Dr. Hopper joined us in presenting a symposium to the community. Oh, sorry. So we thank you. So we had begun our sort of awareness and kind of quest to educate the community, and we held a prescription drug summit so that we could sort of have professionals and community members really begin to understand there's a problem here, we need to do something. And so somewhere around 2013 we started to bring folks together because we noticed pockets of people who were, or programs that were starting to do something to address the need for opiate use disorder. And we came together as a group to sort of learn about this, learn about what other initiatives were happening elsewhere. And one of the things that we came upon was the Project Lazarus, which is a program that was out of West Virginia, where they had just enormous amounts of opioid overdose deaths in a small community, and they took some very specific steps to kind of bring the community together, to change policy, to use Narcan or naloxone as a way to address persons who were experiencing overdoses and sort of bring them back to life, which is what Project Lazarus is sort of named after. So our group went to the WHI, as we were all part of this mental health and substance abuse group, and we said, hey, we really would like to pull together a community coalition that's going to focus on this. And we know we need to have certain sort of work groups that could address various aspects of the epidemic. And so we decided on the Lazarus model, and we had some over 100 people come together over at the Dawn Farm Barn to really kind of look at the community and what could we do collectively as a way to approach this problem. And so we identified the work groups that are similar here. We had maybe some nuances, and we decided that we're going to do an initiative that has a strategic plan for each of these types of work groups, and we would kind of move forward with that. So some of the things that we started out with was some physician education. We had the physicians from the emergency rooms come together, and they started to talk about policies that they had and how do we address it from the emergency departments. And we had the concept of we really wanted the recovery community to be a part of this. So we had another work group working on that to improve treatment resources. Communication group, we felt like we needed to get education out there to the community. So we created a website, and on that website we would host information and events and use that as a place that people could go to get more information about the opiate epidemic and treatment resources and those kinds of things. And so we also wanted to address pain because a lot of the reasons why folks were becoming dependent on opiates was as a result of some sort of pain or injury, and they were prescribed medications. And so we wanted to look at alternatives for pain management and how can we help educate the community. So all of these work groups kind of came together and moved along. We had lots of really exciting things start to happen. Out of that original group, we worked with law enforcement. The sheriff's department was at the table. We decided we wanted to fund Narcan for train all of our officers and supply them with Narcan so that when they got called for as a first responder, they could immediately administer Narcan and we could save that person's life. So we trained the sheriff's department, and then from there we trained all of our law enforcement departments across the county, and then also across my region, which is Livingston, Lenawee, Washtenaw, and Monroe counties. And so a lot of this sort of kind of came out of us coming together as a coalition. And part of that was a way to be able to disseminate information to professionals and stakeholders that came to the meeting. So we'd have ongoing education at the meeting, and then we'd work on projects. And over time, we've really felt like we've started to accomplish a lot. And most recently,
Here we can probably
Yeah.
get to this slide now.
yeah, most recently, we decided to take a look at what exactly have we accomplished and where we needed to go next. So this is an example of some of the specific things that we actually, each work group sort of accomplished. So we wanted to, for example, the big red barrels, that was another initiative. We wanted to make sure there were access points that people could get rid of their extra prescriptions that were sitting in their med cabinets that people could access and get a hold of. Laws were starting to change, so we wanted to educate the community. A couple other things here. One of the key things that is really important in a coalition is the collaboration aspect. So bringing multiple disciplines together. So physicians and sheriff department officials and social workers from all different places, persons in the community, family members, every different aspect of a community came to the coalition on an ongoing basis. So we really had a very widespread approach to this problem. So as we've moved on, next, how do we do the next slide? We decided to really take a look at what we've accomplished and what we need to do next.
Yeah. Well, and I would add to that just that, when we were looking back and trying to document the things that we've done, it was kind of difficult because, as I mentioned, it was a lot of the soft stuff. It was a lot of the having people from different disciplines come together at a table and have a conversation. There was a lot of ideas and things that were spawned at that table. And I think that when, we think about the value add, our value add to the community, it's really creating space for those conversations to happen and creating space for those partnerships to form. So following our kind of reflection back on the accomplishments of the opioid project, we basically spent all of 2018 doing a current state analysis of the opioid epidemic in Washtenaw County. And we did that by examining, 4 different kind of domains. But the purpose in our doing this is we really wanted to make sure that our activities were aligned with the needs of the community. And so we really took a lot of time to delve into where our community was at in terms of the opioid epidemic. So we surveyed providers. This was following on the heels of legislation that passed in Michigan, which you may be familiar with, but it significantly changed acute prescribing, so prescribing in the short term of opioids for pain. And there was a lot of new regulatory requirements and reporting requirements that providers were having to adapt to. So a lot of our survey questions kind of revolved around that. And we also asked providers in our survey, what their attitudes were towards treating people with substance use disorder. And we got some really good data. We surveyed organizations. So we sent out a survey trying to kind of get a lay of the land in terms of what organizations were out there, what programs were out there, what people were doing in the space in terms of treatment, prevention, and harm reduction services and education services, and just tried to get a sense of what was out there and what was missing. We surveyed consumers, and so by that we mean we worked with our partners in the treatment centers at the Washtenaw Recovery Advocacy Project and at the Syringe Exchange to survey people who were actually actively in services, people who were actively using, and people who were in what we would call long-term recovery, to kind of get their ideas about what the gaps were and also to get a sense of stigma, how people were perceiving stigma and where. And then we also did a policy analysis on both the state and federal level to kind of look at the various policies that were shaping our state and our community. And so through our analysis of this, we uncovered 5 major gaps in our community. Lack of pain management resources, or lack of transparency in accessing pain management resources. We heard from consumers, particularly those who were actively using, that they were experiencing a lot of stigma, and they experienced the most stigma when they were seeking medical care. And so this was something that was corroborated. Gap 2, addressing stigma experienced by patients affected by substance use when seeking medical care, was also corroborated in our provider survey. We heard providers talk about how they had difficulty treating this population. And so this was a big gap that we uncovered. We heard from providers and from clients at treatment centers that care coordination was a problem. People getting the information they need to make good care decisions about patients. Treatment access. So, in Washtenaw County, despite our wealth of resources, people were having a hard time accessing the services they needed. And then based on our organizational survey, we found gaps in primary prevention programming and in community education programming. So we took those gaps that we uncovered to our summit in October of 2018, because part of our work as a coalition is to be accountable to our community. And so we wanted to bring our work in front of our community and basically get their input and feedback and to make sure that, you know, what we uncovered aligned with people's perceptions of what's missing and what needs to be addressed. And, you know, our summit was the first summit that we've ever put on as the Opioid Project. And, you know, we had 400 people come. There's a bunch of organization booths there. We handed out 50 naloxone kits.
Yeah, probably.
And we had, you know, representatives from government come. And I think, you know, this is really important in terms of how our coalition interacts with the community and make sure that it's, you know, a lot of our work is very policy focused, and, you know, we work with representatives from agencies. And while our group is open to members of the public, a lot of the work that we do is on the organizational and policy level. So it's important for our group to have this opportunity to interface with the public and make sure that the work that we're doing aligns with the expectations and desires of the community. So after doing that, we took all of the feedback that we gotten at the summit and everything that we found back to our group, and our group hammered out a bunch of recommendations for strategies to address the gaps. And I'm not gonna, it's a very long document, so I've just kind of summarized here some of the key recommendations. We really heard that people were having a hard time finding information, not just accessing pain resources and treatment, but having a hard time understanding how to. There's a lot of asymmetrical information, and so one of our recommendations that you see in many of the categories is increasing transparency around processes for accessing treatment, what pain resources are available, things like that. Our group decided that it was important to monitor policy changes so that we could follow them and advocate where we thought was appropriate, so that you know, a lot of the physicians in our group were really felt, you know, totally overwhelmed by the policy changes. So our group decided it was important to have a more strategic role in terms of the policies moving forward. Addressing stigma. So mostly focused at the provider community, but also at the public. Continuing some of the activities that we were already doing, like expanding access to naloxone and overdose prevention education. And then engaging youth in primary prevention of opioid misuse. That was one of the biggest gaps that we uncovered in our survey of the landscape of services and programs. So that's just a summary. And we basically took all of those strategic recommendations and decided the role that our group was going to play. Because we can't be everything to everyone, and above all, as a coalition, we want to foster alignment. We don't want to duplicate. We want, you know, the people who are doing things and doing them well, we want to elevate them and support them. And the things that aren't getting done, we want to find a way to kind of do those things. And so we went through all of our recommendations and decided the things that we were going to work directly on, the things that we were going to actively support, and then the things like policies and data that we were going to monitor. And we came from the Lazarus model to this kind of new structure. One of the challenges in our previous model with we had 7 subcommittees around me and Carrie at the hub, was actively following all of the work of the subcommittees and remaining accountable to that work and making sure that we were doing what we said we were going to do. So in our new structure, we're endeavoring to kind of follow the work more closely and make sure that what we say we're going to do, we get done. So we have 3 committees. One's focused on data and policy, so that's where the policy advocacy will be taking place. That's the group that's going to be responsible for following the data and making sure that, you know, seeing what impact we're actually having on our community, aside from that soft stuff, from the forming of relationships and the great conversations that happen at our table. We want to see, are we having an impact on the community? Website and communication. So as Marci mentioned, the website is a key piece of our interaction with the community. And so it's their job to kind of make sure that that's a resource. As part of our strategic plan moving forward, we've updated it, and our last slide has our web address on it, but we had some really great public health students who helped us update the website and made it more useful. And that's where we kind of address that transparency issue. We put a tool on there so that people could navigate how to access treatment more easily. We're working on developing a space that really kind of delves into all the resources for people who are struggling with chronic pain and who are having a hard time accessing resources. We break down the multiple pathways to recovery and provide information on that. We provide information on medication-assisted treatment, which a lot of people have a really hard time accessing because there's so much that's unknown, whether your insurance covers it, which it covers, what formulation, where you can access it. And we rely on our partnerships to make sure that all this information is accurate and up to date. And so that's, a key piece of what we're doing. And then we have a whole committee devoted to developing a campaign to address stigma, particularly among providers towards patients affected by substance use disorder. And then at the center is the executive committee, which has representatives from all of the subcommittees and is staffed by the members of the hub. So myself, Carrie, Jimena, our other co-chair, Marci, and a few others who just are committed to the work. And that's kind of our format moving forward. And so that pretty much brings you up to speed in terms of the work that we've been doing. So right now we want to bring a panel of some opioid project members to talk to you about their experience being in the coalition and how it intersects with their work.
Good evening, I'm Carrie Rheingans. I work with Molly at CHART, and I'll moderate our panel. Panelists, I am kind of coming from behind you, so I apologize just because of the mic situation over here. So I wanted to start by asking each of you to introduce yourself, describe your role in your organization, and then also your role as a member of this coalition, the WHI Opioid Project. And we can start. Marci, you have the mic. So.
Okay, I have the mic. So as I said before, I'm one of the founding members of the coalition. My role as the Director of Clinical and Sub Services at the Community Mental Health Partnership is to really sort of ensure that all of the funding that we have through Medicaid, through the federal government, through the state, and even local funds are available to provide services for both treatment, recovery-focused services, as well as prevention. So our responsibility for the four-county region is to ensure that these kinds of conversations help us make sure where those dollars go, make sure that the providers that are providing those services are able to do what they need to do, and that they do it well, and they meet the sort of accountability that is required with these funds that are expended for services. So the other piece to this is my commitment to the community and making sure that each community that we provide services in is connected. And that's why my interest in bringing forth the coalition and making it happen is because it is a way that we can connect with the community, the voices that are out there, have a place for people to come who are interested in partnering with us and working with us is available. So.
My name is Matt Hill, and I am a person in long-term recovery. I am also the program manager for the Washtenaw Recovery Advocacy Project, which is a program out of Home of New Vision. Our program is a recovery community organization with our main goals being to kind of unite the recovery community in efforts to reduce the stigma associated with substance use disorder, provide community education, as well as advocate for people in long-term recovery and policies that support our ability to do that. Kind of a secondary mission that's come out of the success of the Washtenaw Recovery Advocacy Project is working with other communities, especially in our PAHP. So we're working with Monroe as well as Livingston to kind of get their recovery communities organizations off the ground and really kind of work to provide a voice for people with, the lived experiences of going through having an active addiction and entering long-term recovery.
So I'm John Hopper. I'm a med peds and addiction doc, and I have practiced in Southeast Michigan for the last 30 years. Wayne County, Livingston County, and most recently Washtenaw County, which I came to in 2008. At that point, I was already an addiction specialist. I came here as both a clinician and an educator. I directed the internal medicine residency program here at St. Joe's Hospital. And became part of the Opioid Coalition fairly early on because, as every community has problems with addiction, not just opioid problems, but realizing there was a need in this community to improve education among physicians was one of the driving forces for me to be here. And that has to do with both how patients are treated as well as how doctors understand addiction, because there's a huge gap in both how we treat the patients who need help as well as physicians' understanding of the disease of addiction. So I've been really fortunate to work with the coalition from the beginning. My work has been much more peripheral for the last few years because I travel for work now in addition to working here at St. Joe's. But one of the most important resources we have here is we do have some physicians who are very understanding of the disease of addiction, many noteworthy people, Carl Christensen, of course, Mark Weiner. And we do have the only addiction medicine fellowship in the state of Michigan. So if a physician wants to get certified in addiction medicine, there's only one place in the state they can go, and it's here at St. Joe's. And so we started that fellowship about 5 years ago. One person a year. That's all. So that we have to contribute to the pool, the much needed pool of physicians in the state. Nationally, there's less than 50 training programs. So we have obviously a long way to go in terms of educating physicians about what needs to be done. But things are changing, and I think the opioid epidemic has certainly given some weight to this. But again, as an addiction specialist, opioids are just the topic of the day. We have lots of problems that we need to deal with from a substance use disorder, and ultimately the treatment is only part of the picture. And one of the beauties of the coalition is looking at root causes of substance use disorder, and of course that includes education. Pain we think of as a cause of opioid disorder, but really trauma is really the underlying cause for so many people. If we really focus more on both education, trauma, and then destigmatizing and giving people the treatment they need, I think we have a lot of great resources here in this community, and we are making progress.
Excellent, thank you. So we've heard a little bit about what each of you does in your organization and a little bit what your role is in the coalition. And I'm wondering, from your perspective, how has your participation in this coalition helped your organization? It's not just you volunteering your time to the coalition, but what have you gotten from it, from your own perspective? And you can go the other way.
Yeah, I'll just pass it this way. So I think one of the most important things, obviously, is networking, bringing people together, even people with, diverse opinions. Certainly, I have to say, before coming to St. Joe's, I was the director of Brighton Hospital for 3 years. Before that, I worked at Wayne State as the medical director of substance abuse treatment. I directed a methadone program there. I was the first physician in the state to prescribe buprenorphine. Not everyone agrees with my perspective on making treatment widely available with a wide resources of treatment, including methadone, which I think is an important treatment option. A lot of people don't agree with that. That's fine. But I think the coalition really gives us the opportunity to bring in different perspectives and also destigmatize, because I think whether you agree with the treatment or not, it's important to not stigmatize people who are trying to get help.
So in my role with working with the Opioid Project, I've had the opportunity to be a co-chair on the Stigma and Community Education Committee. And it's kind of enhanced the work that we've done on our own day-to-day operations at RAP. Kind of our main focus in reducing stigma is kind of shifting the narrative to showing stories of recovery versus faces of addiction. And kind of with that, it kind of creates this problem when trying to address provider stigma, primarily because a lot of providers see only the faces of addiction. Once, somebody is able to get the treatment and the help that they need and enter long-term recovery, they're not in the ERs, multiple times a month. They're not having a lot of the same issues that they were in active addiction. And so kind of being able to have a forum of professionals across the board, whether it be people with lived experiences, people that work in the treatment kind of field, people, providers as well, we can kind of bring that message of recovery to providers, whereas then they're not really seeing that recovery aspect of it on a daily basis. In just kind of being able to bring everybody together in one kind of shared forum has been real instrumental in being able to look at stigma and how to go about reducing stigma in a number of different ways across a number of different disciplines. And I think that's been the biggest, I think, success from, bringing all those people together.
So I'm in a reflective mode in general because I'm going to be retiring. So when I think about some of the accomplishments that we've been able to achieve by this collaboration, I really am looking at what the Opiate Project has enabled me to do as the person that's sort of responsible in making sure that the treatment opportunities, the available programs across my region are, and sitting at the table with multiple disciplines, with persons in recovery, with physicians, with nurses, with law enforcement, and many different sectors of the community has given me the opportunity to really sort of be creative. And how can I sort of take all of that and turn it into something that we can use as a mechanism in our community? So for example, the RAP program. We know that we wanted the recovery communities and the voice at the table. And we know that one of the programs that we were trying to launch over the past several years was a recovery community organization. We had written a grant for it. We weren't funded through SAMHSA, but we also had a will and a way, and we were able to say, well, this is really a good outcome from this community because we've got lots of recovery folks, and we know we want to have some sort of initiative out there, and we were able to find funding. We were able to coordinate those services. Bringing peers into the mix has been just an incredible experience for us. Another thing is when we talk about law enforcement, well, there has been so many developments just because law enforcement was at the table. So not only were they willing to start their training and kind of implement the Narcan, administration of Narcan by law enforcement first responders, but they were inspiring to other departments. So we were able to kind of say, okay, well, we'll buy the Narcan, and if you guys start to get trained and use it, then we can show other police departments how successful that is. And so we were able to kind of build upon that experience. And all of that came from sitting around the table with other folks. So we were able to kind of take those concepts. I had the funding. I could dig up the money and we could fund it, and then, these new established programs are out there now. It's standard of care that our law enforcement folks. Then we were saying, well, geez, if law enforcement could provide this, then why don't we train the community? And so our providers were getting training. We do community work. So a lot of what happens just from sitting together enabled us to really build the programs that we have now in our community. So it's been an incredible experience.
So thank you, Marci. My next question was going to relate to how the Opioid Project has benefited the community, but each of you talked about that in your response to how it benefited your organization, because I think you couldn't resist. Because, that's how a community coalition works. It benefits the community. So if you have anything to add, you can add it in other responses, but I do want to ask about this value of community coalition work. What is the most valuable aspect, do you think, in your opinion, of doing coalition work as opposed to just doing the work at your own organization, right? So St. Joe's trains an addiction fellow every year, right? That's a great benefit, but what is it about a coalition that could be even more of a value in the community? And you can take take this in any order.
I mean, there's so many added benefits that it's kind of hard to narrow down on one. But I think largely, kind of the two main ones being that when you're looking at the opioid epidemic and addiction in general, there are so many factors that play into so many people's, stories. A lot of times it's unstable housing. A lot of the times it's mental health issues. A lot of times it's, previous pain. There are so many factors in kind of spurring somebody down, a road of active addiction, and having a community coalition where we have people from Avalon sitting in with us. We have people from the Ozone House that's working on primary prevention in our youth. We have, providers, we have shared experience, all coming together on at one table. We can provide and kind of at least strategize ways to provide those wraparound services that really enable people in our community to have the best chance to recover. And kind of going in on that, I think everybody that's involved in the addiction kind of field can say that, a lot of some of the shortfalls that we have come with funding, and how, relatively speaking, in the past 20 years, funding hasn't increased all that much. And I think having various different programs come to the table that all have their own funding source, and kind of have funds set aside, and being able to collaborate to kind of maximize the effectiveness of all those funds really kind of creates the community response that is going to be needed, and not just for the opioid epidemic. I mean, addiction has been around for decades, and so kind of like the last, I think, most important takeaway from the community coalition is that we're now taking the strides that's not only affecting the opioid epidemic, but addiction in general. And it's going to continue as, we hope to see the numbers of, opioid deaths decrease. The work that we're still doing is going to go so much farther than that, to opioids, benzodiazepines, all drugs and alcohol, gambling, and kind of reducing that stigma in going forward.
Yeah, and I would agree 100%. I think that the work of the coalition, because everybody's at the table, you can garner support for new initiatives. A lot of times there may be grants coming down. We all sort of talk to each other about, gee, would you support this grant, or could you help us write it? Being able to support each other in some of these initiatives. Another way that we've been able to come together when there are policy changes at the state or even federal government. For example, we've just had a major change in our administrative rules. Well, there's some things that we're not happy with, but using the collective voice of people around the table, we're able to at least share in sort of voicing those concerns, complaints, whatever. So we have that political sort of aspect of being able to share some of those concerns that we have. Being able to bring new things to the table. So, for example, where there may be a new treatment modality or a new model to implement. You mentioned gambling. So gambling is another thing that has just been addressed, in terms of funding, needs to be addressed, that we have a growing gambling addiction problem, and it coincides with substance use disorder. And so now we need to really kind of address it. We need to look where we can to provide prevention services. We need to look at persons who are coming into services. How can we help them if they happen to have a gambling disorder? How can we identify it? And those kinds of things. So having a forum of professionals and community members to kind of share that information is really a unique thing. So bringing all these things to a place and sharing is really important.
So your presence here is really the part of the success of the coalition. So the coalition obviously represents its stakeholders, but you're ultimately the stakeholders in the county. And policy change is ultimately going to come from the conversation that you all are involved in that leads to good solutions. And I'm reminded of look, if you go to La Crosse, Wisconsin, it's the community in the United States that has the highest prevalence of advanced care directives in the county. So advanced care directives are basically living wills. And so even people in their 30s and 40s have living wills in La Crosse, Wisconsin, because they recognize the importance of this for end-of-life planning. It's just part of the community conversation there. You're kind of, it's just something that happened from a grassroots community coalition. And ultimately, that's, the potential for a coalition like this. You're all part of the conversation here. Policymakers don't necessarily listen to science. They don't necessarily listen to, good academic stories. They listen to what you have to say, and the conversation really is going to be best if you're part of that conversation in terms of what solutions we're going to need in this county.
Thank you. So I do want to allow questions from the audience. If you do have questions, I have one question for the panel to give you some time to think. But if you do have a question for the panelists or Molly or myself, you can ask it in a few minutes. So think about what you might want to ask. I wanted to ask you as panelists and coalition members, what are some of the biggest challenges of working in a coalition or working to address addiction or opiate use in our community through a coalition model? What are some of the biggest challenges?
Yeah, I think the challenge remains that there isn't a one-size-fits-all model for whether it's treatment or prevention. There's a lot of different pathways, and each person has sort of their own, perspective, and trying to get all those in the room and recognizing that everybody has a valid perspective, but ultimately, some things are going to rise more in terms of what people want to do versus others. And I think whether it's treatment, prevention, both are important, but you can't do everything given that a lot of this is done on volunteer time. It needs more people and more input.
Yeah, I definitely would say that, with everybody that's coming to this table having a full-time job and supporting programs of their own, it does provide that opportunity to come together, but at the same time, there are some limitations as to how far collaboration can go at a single meeting. I will say that, though, we've been fortunate enough to have a backbone like CHART that can facilitate more of the time-intensive activities that go into bringing the group together. I think that the people that we have at the table are able to make a lot of the initiatives and a lot of the discussions that we're working on kind of fit more seamlessly, I guess, or at least try to start that process in our day-to-day, jobs. But at the same time, I don't think that the limitations to working in a kind of collaboration like this or a collective group like this, I don't think the limitations. I think the limitations are a very small price to pay for the benefits that we get out of it.
Yeah, I would agree with my fellow panelists. One of the things that I think is really difficult, and we've struggled with over time, is being able to sort of take that time to sort of make things happen relatively quickly. And I think it's because so many people are so busy and we only have a little bit of time. And we actually made the commitment to have the meeting have work time. So for the work groups, you come to the meeting, you get to work on the work group. And some of our work groups have actually met outside of the meeting, but that's getting that time to kind of stay on task, to make things happen, to move things forward, really takes a lot of effort, which is why we really need more folks to join in and help out. And we've had many people over the years come and give to the committee, and then be able to contribute and then sort of back away for whatever reason. So being able to have one, folks that are consistently coming to sort of make that commitment is really a challenge for any coalition. And what really helps it, though, as you said, having a designated coordinator, that really does help. So, thank you, Molly.
So is there any questions from the audience before we continue on? If you have any questions, yep. So your question is, when we work with youth and young people who feel invincible or who think they might be invincible, if they think that marijuana use is not very dangerous, but the film that you saw shows that it might actually be dangerous, you're wondering how we can do some education among young people who might not think it's that big of a deal, right? And this is similar. So one of the gaps that we found in the last year of doing an analysis with our partners and with different community members is that there is a gap around education among youth and targeting youth. And so do you want to talk about the, yes, I heard you moving. So go ahead and tell us a little bit about the link or not link about marijuana.
Well, honestly, I could talk all week about adolescent substance use. Ultimately, communities that are successful in reducing adolescent use of drugs and alcohol, it's a community approach. Like it goes well beyond the little bit of time they have in school in terms of what teachers can teach them. Parents are actually one of the primary drivers, and the community itself is a driver. So Ann Arbor, one of the great things here is we have the Tobacco 21 law. Should be Tobacco 25 in my opinion, but the fact that you can't buy tobacco products till you're 21. Now, it should be all nicotine-containing products. That's one of the most important things that everybody in this room can do is really advocate for. It's not just tobacco products, but nicotine products are dangerous for developing brains. Once your brain's developed, nicotine, it's fine. But for the developing brain, dangerous drug leads to much greater risk of stimulant misuse in adulthood. So if you want to predict cocaine use in the future, methamphetamine use, nicotine use in childhood is a big problem. So that's an example of trying to protect developing brains from all mind-altering substances is a community-wide effort. And that includes, laws about what's accessible to youth. And banning drugs doesn't make the difference. It's just getting people, adults, to agree that kids shouldn't be using these things. For the adults to make a decision about drug use is an adult decision, but it's not an appropriate decision for kids. They're not able to make these decisions because they are invincible. So again, we can talk all day about it, but the idea is really it is a community effort. Buying alcohol for your teenage kids to drink at home is not a good thing. Drinking in a controlled environment is no better than drinking in an uncontrolled environment for a developing brain. So that's an example of the kind of thing that really is going to change adolescent use. But
And I will say, one of the things I heard you say is that you're frustrated. You are frustrated that you go to these meetings, you hear people say similar things over and over, and you're not seeing a change. And I think since that's one of the gaps we discovered in our analysis, is that there needs to be more of this education and focus on youth and preventing youth from even using substances in the first place. That is something that we're working on developing over the course of the next year or so. And so we are always welcoming people to join our groups and help us figure out how to do that. And it sounds like you might have some good experience to help us figure that out. So we do have these little guys out in the hallway out here, and at the bottom it says learn more at whiopioidproject.org. If you go on there, you can find a way to contact us and get in touch and join one of our groups too. It would be great to have you with your experience on a group. Any other comments about the youth prevention?
I think what we know about prevention, and it really doesn't matter what substance we're talking about, we look at the risk factors and we look at protective factors and how can we sort of build those. in the community with families, with kids. So we want to work on a multiple layer basis. So that's how we approach prevention. I know there are coalitions, local coalitions that are trying to address the problem. And you're right that we fight just like, and there's hope. Let me just say that. There is hope. We fight the battle of, gee, we don't want to be identified as a school that has drugs. So we don't want to say that we need these education programs. So that's one of the things that we fight. We fought that battle with our law enforcement officers. Why would I give somebody Narcan when they're just going to go back out and use again? What we found is that once folks started to save lives, they were like, this is the best thing since sliced bread. I feel very committed. So attitudes change, things happen, so there is hope. And we have made strides in our schools. Our schools at first didn't want to do these youth surveys that help us kind of identify where the problems are. And eventually, because the state was pushing it, and eventually they found that, gee, we do need to know about this. We do need to help our students. So there is ways to kind of keep the ball rolling, and there's hope.
Yeah, so the question was, Marci had referenced changes to administrative policies, and was wondering if we could explain a little bit more what those changes were and why there was some frustration.
So I think this happens with a lot of policy development. The Licensing and Regulatory Affairs, who oversees all the licensing of substance abuse programs, made changes to the substance abuse rules, which in some cases was really something we want. They hadn't been changed since 1983, and our rules were very antiquated. So we had been asking the state to, let's get on the bandwagon here, let's modernize these rules. What they did was they changed the rules requiring programs, like for example, our detox programs have to have certain medical staffing, and we have a standard of care across a national standard of care through ASAM, which is the Addiction Medicine Society, American Society, yeah, thank you. Our ASAM doc. And the state sort of implemented these rules without consideration for our comments, national standards. So it places some of our programs at risk of getting dinged on their licensing. So we were working with them, and no matter how much we testified, they changed the rules anyway, and they didn't listen to us. So that's where the frustration has been. So we advocate from a collective perspective, we advocate to the state on some of these kinds of issues. Now, that wasn't the only thing that they changed. They did do some other things that we're still haggling with the state on. So one of the rules is to have a detox facility have a medical staff 24/7. So we have been operating a national standard of what we call it's casually called a social detox, but it is a detox facility that's abstinence-based but also supported, that doesn't necessarily need a medical professional 24/7. We've operated them safely since forever. They're nationally recognized. They're part of a continuum of care, and we do have other opportunities where we have higher levels of care for detox facilities for folks that are medically compromised, that we could make sure that we have those medical professionals available. But our general detox programs, in order to convert them to that higher level of care, requires physicians and nurses to be on site 24/7. To meet the licensing standards. So it's an unnecessary requirement.
Yeah, so I think Suboxone or buprenorphine has been part of that conversation for the opioid coalition since the beginning. There's, no doubt that there is not enough availability in the county for the patients who could benefit from it. There is a growing interest in prescribing it, but there are a lot of barriers to prescribing. It requires prior authorization. The state, despite all its best efforts, has not been super friendly for patients to use this as a maintenance therapy. They have sort of one-size-fits-all rules around a lot of things like drug testing and counseling. Counseling's super important, but different people benefit from different levels of counseling, and there's sort of a one-size-fits-all approach to everything that's done. And again, there's lots of things that we do in medicine that don't have nearly as many restrictions or regulations. It's just one of the most regulated areas of medical practice, and not necessarily with a lot of science behind the regulations. Yeah.
And I think talking about Suboxone in general kind of highlights how a community collaboration is so important, because on one hand you have all of the medical considerations to consider when looking at Suboxone as a potential pathway to recovery, and then you go on to the lived experience side of looking at the recovery community, and a lot of people that have come before us in recovery, that have 10, 15, 20 years, that their pathway to recovery was a traditional 12-step program. You kind of have stigma within the own recovery community about what other people's recovery looks like. And so being able to bring these conversations to the table so that, when prescribers are looking at, potentially using Suboxone or methadone or Vivitrol as a means to help along the road to recovery, having that knowledge that, in the recovery community itself, that's also can be looked down upon, and kind of having that knowledge and being able to direct patients in the right way to programs that are supportive of Suboxone as a potential pathway to recovery. It's kind of that whole person approach that the collaborative really aims to take on.
So the question is, in a coalition, there's probably conflicting viewpoints. How do we accommodate or address all those conflicting viewpoints?
Great question. I think that one of the things that we've done at the coalition is really bring information and education to members. And I think that we run into the philosophical challenges every day in our treatment providers, in communities and families. It's almost an age-old question, and we've run into it over time. I can say that in my career, I have seen things swing completely to a different perspective. So back in the day, it was very frowned upon for folks to go for opioid replacement therapy, which is methadone. There was a complete and total stigma for that population, in part caused by all of the regulatory requirements for those folks, having to go every morning to get your dose, and like all of the other stuff that goes with it, the population, the stigmatizing names for folks that have an opioid addiction, those kinds of things. That sort of carried through. But as we started looking at multiple pathways for recovery, and we started to think a little bit differently, and the newer medications came out, there's still folks that vehemently oppose medication-assisted treatment, but there are many who are really looking at it in very different ways. Plus, it also has been mandated by the feds that we start providing access to this kind of medication assisted. It is a medical practice. They're sanctioned medications for persons with opiate use disorders, and we see very positive outcomes. We can look at it as a harm reduction. We can look at it as a pathway to folks who can begin to sort of titrate off of it and move towards abstinence. There are many people that are going to be on maintenance for as long as they need to. So there's varying degrees. And in the project, by being able to sort of have those information about those kinds of treatment opportunities helps to sort of lend the conversation on, how can we help you understand this better? We're still going to have those folks that are abstinence-based only, and that's okay. But we have to be open. We have so many folks that need these services, and if that's the pathway that they are going to best follow, that may be the best way that we have to go.
So kind of to recap the question, first part of it was how do providers go about identifying patients who may have had opiate use disorder in the past and are coming in for some sort of procedure or surgery where they would need opiates to manage pain. And I think the general question in there was along the lines of how do you balance knowing as a provider that somebody may have a history if they're not forthcoming, whether it be due to stigma or other causes like that, and B, how do you kind of manage prescribing opiates to somebody who may have had a dependence in the past to manage that pain, and also how do you go about the follow-up to make sure that that procedure didn't lead to a relapse?
The idea, again, patients do feel stigmatized, and it's hard for them to be fully upfront with somebody they don't know well about what their history is. It's definitely a risk in practice, and the risk is certainly obviously great in somebody who is going to be giving an opiate to somebody. And I think the best you can do is really just be honest with people. What are the risks? And be very, matter of fact that getting the history includes not just the personal history, but the family history as well. So somebody who has a family history of drug and alcohol use is also at risk for misusing an opioid. There's lots of people who, because of their parents' addiction, didn't use themselves, but if they come into a setting where they get exposed to something, even late in life, like a benzodiazepine or an opioid in their 30s, but they never drank, never used drugs, but they're going to have a very different reaction. I think, again, a thorough history is important. Patients will only tell you what they are willing to tell you. I think being open and empathetic, but also exploring the family history is important because that is often like a clue to somebody who's at higher risk. I guess there's a lot more you could say about it in terms of how to approach this, but it is it's under-recognized how important the family history is in terms of addiction.
Sorry, and I also wanted to comment on your payment question, and then I'll let you, if it's not related to payment. So the other question you asked about, it's, a health insurance company doesn't pay for you to do the follow-up, to check in on somebody. And my response to that would be they don't pay for it yet. So part of what we need to do, if that is something that is necessary, part of what we should do as a coalition is think about how do we use our voice, how do we work with experts at the U, at St. Joe, and in the community to say this is a change that needs to happen in a health insurance policy. And then the health insurance companies can examine the data for themselves and hopefully choose to do the right thing because it's the right thing and also because it might be a benefit to them as a company, so.
So one of again, it's all, language is super important. So when I'm asking a patient, I'm going to prescribe an opioid, I don't say, have you ever had a problem with opioids? I would say, have opioids ever caused a problem for you? I mean, that's a question. It's a yes or no question. And, I hope that people will be honest about it. But it's very different from asking, have you had a problem with opioids? You can just see how just a subtle difference like that can make a difference in terms of how somebody's going to respond.
Yeah, I just wanted to add to that. I think it's really great that there's so many medical professionals who are committed to mitigating the impact of opioids. But I think it's important to remember that patients have agency And while pain and opioid addiction are definitely related, there's a lot of, I think, the pendulum is swinging this other way now, where people who are experiencing pain, even if they do have a history of opiate use disorder, aren't necessarily able to get the treatment that they need. And so I just wanted to maybe just voice that patient agency is important. And as a person actually in recovery from opiate use disorder, if I'm in a lot of pain, I don't want somebody to make that decision for me. And so I just think it's important that, when you're building this relationship with your patients, it's not just their history and not making decisions on behalf of patients, but making decisions with patients. And I think there is some, this, new law around informed consent. I think it's good because it's going to start fostering those conversations between medical professionals and patients. But I think that the conversation shouldn't stop at, liability for that outcome. So that's all I wanted to say.
Right, yeah, so it's like the protocol of what do you discuss prior to surgery, what is the impact, how can we sort of follow up post-surgery, those kinds of things. And I can tell you that I've had surgeries myself, and the insurance company nurses are calling me. I was really surprised that, they were following up because of whatever I was having, but why don't we have that as a protocol? And this is where the coalition can help. Those kinds of issues, we have physicians at the table, we've got policymakers, we can sort of rally the troops and say, hey, we need to go to the legislators, we need to go to the state and have this, our partners at the state can help advocate for those things. We can say, hey, can somebody talk to the insurance commissioner and start looking into these kinds of practices? That's what the beauty of a coalition can do, because there are many people that touch other folks out there, and maybe we can begin to kind of target those solutions. So that's why we've got our pain management group, and we're looking at what are alternatives for pain management, how do we help educate folks, how do we get legislators to sort of make some decisions and bring these things to the attention of the right people, if you will. So the coalition is a great place to do that.
And with the coalition, you have kind of a number of ways to approach this. We're also looking at this primarily, just this question in general, from a provider standpoint. And I think Molly hit the nail on the head quite well when she says that people in recovery have agency. And I think bringing together groups of people and having, kind of the component of the coalition that works with people in recovery, creating anti-stigma messages, not only to providers, but incorporating that into substance use treatment so that people in recovery know how to talk about themselves in a way that's not stigmatizing. I can tell you from a person in long-term recovery, in having started my journey in recovery in Dallas, moving to Michigan and reestablishing connections with a primary care physician or even the dentist, having the terminology to go away about it that isn't stigmatizing to me because I'm using messaging that isn't stigmatizing, and B, me taking that initiative and kind of being prepared for that has made the conversation with my providers go much easier because I think a lot of times with the conversation revolving around trying to shift blame onto one person, that conversation between a provider and a patient can be uncomfortable just because of all the garnered attention of the opioid crisis.
So the question is about what work have we done with the schools for prevention? Is that?
So this is something kind of new that the Washtenaw Recovery Advocacy Project is slowly moving into. We've tried a couple of different approaches. The main approach, or one of the approaches in the past of doing it large scale with a public school system, is often very cumbersome in terms of dealing with the Board of Education and individual school administrators. Through kind of word and mouth and collaborations among the community, we actually had health teachers at Saline High School reach out to us personally, so circumventing even so far to say as the school's administrative staff and just working specifically with those teachers to be able to get into these schools, kind of give a little short education piece about opiates and addiction, which I can tell you in school, I had that, but at the same time, I mean, I still found myself in a situation and, you know, a pretty dark active addiction. What that message didn't include in school was what happens when you find yourself there. And I think a lot of the problem with parents not allowing this education into the schools is because they have this mentality of, not my child. I can tell you my mom probably never imagined in a million years that I would have had the struggles that I did. But the fact is, if we don't prepare and don't show our youth what recovery looks like, when they get to that place, they spend a longer time period there not knowing what those next steps are. I mean, I spent 5 years on the campus of the University of Michigan going to school and had no idea what kind of recovery community Washtenaw County actually was. So it would make sense that, you know, when I found myself needing that help, that some of the education that I got beforehand should have probably included, you know, messages of recovery, how to, you know, what resources are in our communities. And surprisingly enough, the kids that we did this for, like I said, we did a short part about kind of what addiction is, what it looks like. They asked us specifically to focus on opioids. But then a larger percentage of it was personal stories and kind of how we got to where we are to, you know, kind of stand before them. And I think that's, you know, one of the approaches to have, I guess, in stigma education in our schools.
Just real quick, so we try in our prevention efforts to have a variety of programming in the schools that are evidence-based practices. So for example, there's programs that are called Project Success. We've got around the region, we have what we call the student leadership teams, and those are activities that groups of kids like sign up for, and they engage in these year-long events at their school. So there's a lot of sort of education and efforts in the schools to sort of do that. But from the opioid project perspective, having a speakers bureau is one of the ways, well, even through RAP, is one of the ways that we can kind of get in. But we struggle with policy and sort of the whole sort of the stigma piece, but also the worry that if you talk about drugs and talk about addiction, somebody's going to get that and they're going to become, I mean, it's like that kind of thinking that we have to kind of work around. So I think that's, you know, a realistic problem that we have.
And sorry, I just wanted to add one more quick thing. On that, you know, our youth and our kids are a lot smarter, I think, than we give them credit for. The questions that we got, you know, the idea is that kids are out there trying this because it sounds like a good time, when that's not the case at all. A lot of the questions that we were getting from the students were very centered on mental health and, you know, did it really solve the problems that you were having in your life? I mean, kids are smarter, and I think having a more honest conversation.
And I just have to add, because I know we're short on time, you know, when it comes to prevention in the schools, really there's general models that are general prevention efforts, targeted and tailored depending on the level of risk. But the biggest general prevention thing that actually leads to best health outcomes, less drug use, is early childhood education. Being able to read well by 3rd grade universally is the best thing that we can do for society, really. So again, you know, as a community, focusing, like if we want to prevent drug use 20 years from now, that's where the money is.
So it is almost 9 o'clock, so we're not going to be able to take any more questions, but I do want to thank all of you for coming tonight, and we'll be here for a few more minutes. Like I said earlier, we do have these quarter sheets out on the table if you'd like to join any of our groups or come learn what we're about. We do want community members to be involved, and you know, the work that we do is effective within each of our organizations, but also is more effective when we all are working together. So if you want to join us and start working with us and help us work even more in our community, we would love to have you. Thank you.